All right, so welcome everyone to the Research Brown Bag. I'm really pleased to introduce our speaker today, Professor Art Reingold, Professor of Epidemiology, as well as the head of the Epidemiology Division. Art has an extensive background in vaccines and vaccine-preventable diseases in all kinds of different settings. And of note, he was recently named the chair of the California State COVID-19 Vaccine Work Group, focused on safety and efficacy of the vaccine. So I know there's probably a huge group of us eagerly awaiting what updates you might have to share, Art, and thank you so much for making the time amongst what must be a very, very full schedule. Thank you.
Thanks, Jen. Can you hear me okay? Everyone hear me okay? Great. So I'm going to have Lauren advance my slides. I don't seem to be able to share my screen, so thank you for that. So what I wanted to do is give people an update and then leave plenty of time for questions. And as you'll see, what I've done in terms of this talk, a lot of the slides and headlines and whatever actually come from the New York Times. And I have to say, I think the New York Times has done an extremely good job of publishing things every day that are quite accurate. So I would also commend that source to those of you who want a shortcut to what's happening. The next slide. I should say one other thing. This is such a rapidly moving field that if I made the slides yesterday, some of them would be out of date by today. And in fact, I made the slides on Friday and over the weekend. So many of you will be familiar with the fact that here in the United States, we've had over 500,000 people die of COVID-19 over the past year or so. And that number continues to go up at approximately 1,500 to 2,000 deaths a day currently in the United States. And there are good reasons to think that this death toll is actually underestimated for reasons I could talk about if people are interested. The next slide. And again, this you can see is already quite old. This is a week old, the coronavirus case count, if you will, for the United States, as shown in the New York Times. But of course, what's important to point out here is that there's been this steep decline in the past several weeks, although if the additional week of data were here, you'd see it's kind of leveled off at this point, raising concerns that perhaps we're not out of the woods yet. And of course, I would point out, as most people would know, that this number of coronavirus cases of 28 million is really somewhat of an unhelpful number because it really relates to who's getting tested and why they're getting tested. And we know that there's a lot of asymptomatic infection, a lot of mild symptomatic infection. So we know that there are probably at least 2 or 3 infected individuals for every person identified in this number, perhaps more than that. And there are studies that show the extent to which these numbers really undercount by a lot the number of people who've been infected with this virus in the last year. The next slide. And this also shows that fundamentally this decline in numbers of identified cases is certainly being seen in a number of other places, but by no means everywhere in the world. And again, I think these numbers should be taken with a large grain of salt. The next slide. So I'm not going to talk about all the other approaches to preventing transmission of this virus. The non-pharmaceutical interventions like social distancing and masking, we can talk about those later if you want. The talk today is focused on vaccines. And so you'll know that over the last year, a number of companies have worked hard to develop vaccines against SARS-CoV-2 virus, the cause of COVID-19. There's something like 200 groups that have been trying to develop vaccines around the world. And generally, the different approaches they've taken have been this novel approach using messenger RNA, using viral vectors, particularly adenoviruses, to introduce the gene for one or more the SARS-CoV-2 proteins. Some groups have used the inactivated whole virus. Others have used that should not be protein submit. It should be protein subunits. I apologize for that. I just noticed that mistake. So you can see at least these four major different types of approaches to making these vaccines and doing it as quickly as possible. The next slide. So just to remind people that here in the United States, at least, we have a fairly routine process for developing and testing vaccines. In this case, it's been done at a rapid pace, but all of the steps have been followed. Preclinical testing typically occurs in one or more animal species, such as mice or monkeys, to make sure that something produces an immune response. But ultimately, if you want to know what something does in people, you need to test it in people. So phase 1 safety trials and immunogenicity trials typically involve dozens to perhaps a couple of hundred people. These are typically healthy adults. And basically the primary purpose is to make sure that whatever the proposed vaccine is safe, as best one can discern it in such small numbers, and that it stimulates an immune response. The next slide. Then typically we go on to phase 2 and phase 3 studies. Phase 2 studies typically involve hundreds of people. They are done now in what's hoped to be the target age group. So if the vaccine is intended for infants, these trials would involve infants. If the vaccine is intended for old people like me, it would be given to old people like me. And these studies again look carefully at safety and the immune response, and they also typically look at different schedules, 1 dose, 2 doses, spacing between the doses, in order to measure the immune response and the like. And again, ultimately, if you want to know whether a vaccine is going to provide protection, which is what we care about, protection against infection or disease, ultimately you have to do phase 3 efficacy trials in which people are randomly assigned to get the vaccine or to get a placebo or potentially some other a vaccine that is quite different and wouldn't protect against what we're trying to study. And then the endpoints can be any of a variety of things: symptomatic infection, asymptomatic infection. It depends on how the trial is designed. And then once all of that is done, the information is presented to regulators. In our case, it's the U.S. Food and Drug Administration. And then after that, people like me then do what are called phase 4 studies once a vaccine is in widespread use to look at its effectiveness in the real world, and also to continue to look at safety once a vaccine is being given not to a few thousand people or 30 or 40,000 people, but to millions or tens or hundreds of millions of people. So that's the process in the United States. The next slide. Not all countries follow that process. There's no international body that says that's what you have to do. Many of you know that Russia and China have begun using coronavirus vaccines where all of those steps had not been followed, or at least the data had not been reported. And the argument, I believe, fundamentally was that this was such an important problem that they had enough information to make it reasonable to start vaccinating people. But of course, this does then feed into concerns about safety and also concerns about efficacy. So the next slide. This is just to say that in the United States, the regulatory authority for drugs and vaccines is the U.S. Food and Drug Administration. And when it comes to a drug or a vaccine, they can license the product immediately, or as in the case of the vaccines we're going to be talking about, they can approve their use under what's called an emergency use authorization, an EUA. It's interesting that whether if it's licensed or approved under an EUA matters in some instances, such as, to take one example, apparently whether the US military can require troops to take the vaccine. So this distinction does matter, at least for some things. But FDA then continues its oversight of drugs and vaccines once they're being used. The next slide. So, so far, the FDA has approved 3 COVID vaccines under emergency use authorization. The Pfizer vaccine, which is a 2-dose mRNA vaccine, the clinical trial showed 95% efficacy. That was approved by the FDA on December 10th of last year. The Moderna vaccine, the one that I got my 2nd dose last week, is a very similar mRNA vaccine with a virtually identical efficacy. That was approved on December 17th. And then if you were paying attention last Friday, the FDA approved the Johnson & Johnson vaccine. This is an adenovirus vector vaccine, so a very different kind of vaccine. And I would point out that this vaccine efficacy of 66.9% is somewhat misleading. It does raise concerns in some people's minds, but in point of fact, the efficacy against severe illness and hospitalization is higher than that. In addition, there were no deaths in the vaccinated arm of this trial. So the suspicion is that this vaccine actually has much better efficacy than reflected by this particular figure. And the advantage this vaccine has over the other two advantages. One is that it's 1 dose instead of 2 doses. And also it can be stored at refrigerator temperatures, making it easier to use in the real world. The next slide. If you study vaccines, there are a lot of things you'd like to know about them. How well do they protect against the disease? How well do they protect against infection and potentially transmission of the infectious agent? How well do they work in various subgroups? This is particularly true, for example, in different age groups, for example, or whether you have underlying illnesses such as cancer, whether you've had a prior infection with the agent or not. So these are important issues that really have not been fully addressed by the trials we have so far, because the trials simply aren't big enough to include large enough individuals in these groups to provide narrow confidence intervals around point estimates in these subgroups. Again, short-term safety, which is typically refers to adverse events within the first 6 to 8 weeks following immunization. Many people have raised concerns about what they call long-term safety. We can talk about that, but basically there are no well-established long-term adverse events from immunization occurring more than 6 to 8 weeks following immunization. So while many people raise this concern, there's really no evidence that vaccines have a long-term safety problem. If we're going to co-administer a vaccine, in this case, for example, with influenza vaccine, we need to study the effects of co-administration. And for these vaccines, it's an increasingly important question whether they'll work against the various variants of the causative virus as they continue to emerge. The next slide. So normally, the way a vaccine goes through this process, as you've observed if you were reading, watching the press the last few months, is that the company or whoever produces the vaccine would prepare a very large, voluminous set of data and results, submit all of that to the FDA. Their Vaccines and Related Biological Products Advisory Committee meets, an independent group. They would vote, presumably, if they vote to recommend that FDA approve the vaccine, the commissioner of FDA then typically acts on that recommendation, and the FDA authorizes use of the vaccine, which is, as I've said, a regulatory step. In the United States, the CDC's ACIP Advisory Committee on Immunization Practices then meets, and they also make recommendations about the use of the product to the director of CDC, who typically takes that advice and agrees with it. And what's a little bit different about these COVID vaccines is now some states have decided that they will review these vaccines separately. And Jen referred to the fact that I chair a committee that's doing that. Initially, well, if you go to the next slide, initially the governor announced that it would be California following New York's lead, but then California was joined by Nevada, Washington, and Oregon. So we call ourselves the Western States Scientific Review Working Group, which I chair. We met last night, in fact, for several hours to go over the Johnson & Johnson vaccine, because we don't want there to be any delay between when the FDA and the CDC approve a vaccine and when people in California and the other states would have access to it. So we typically meet basically the same day as the ACIP in order to weigh in. The existence of this committee and the one in New York is quite controversial in public health circles, and I'd be happy to talk about that. But fundamentally, I don't think we want to live in a universe where individual states are making decisions about what drugs and vaccines are okay to use in that state. It's also not clear that our advice actually matters from a regulatory point of view. If a provider in California wanted to use a vaccine that's been approved by the FDA, I don't actually think they care what our committee thinks, but we could talk about that. Our committee was basically stood up by the governor because last year the feeling was the FDA and the CDC were sometimes making flawed, politically inspired decisions, and that an independent group at the state level could potentially provide reassurance and help with uptake of a vaccine. But as I said, it's controversial. The next slide. We can skip that. That's just a headline from when we approved the Pfizer vaccine. Now, clearly, all that research is great, but as you all know, if you want millions or tens of millions or hundreds of millions of anything, there's a manufacturing process involved, a filling and finishing process to get things into vials, distributing it, the product, which if it requires ultra cold temperatures, adds to the complexity. And then we come to all of these issues about who should get the vaccine first, if there are limited numbers of doses, equity with regard to distribution. As I've said, we monitor the effectiveness and the safety. And then, of course, we also invariably have some concerns about whether people will accept a vaccine or not in a world where vaccine hesitancy is already quite widespread. The next slide. So I was privileged to be on a National Academy a committee last summer, or last fall actually, that wrote a report on, produced this framework for an equitable allocation of COVID-19 vaccine. And the next slide just shows one figure from that, trying to lay out phases of who should get the vaccine first, phase 1A, then phase 1B, et cetera. This was an enormously complicated discussion. A very similar discussion was had by the ACIP, as well as by ethical review groups convened at various other locations. I would say that for the most part, this entire exercise was a waste of effort, because as far as I can tell, very little attention has been paid to any of this, as individual states have decided whom to vaccinate and in what order. So it's a little bit sad to think about all the time we invested in this report, but I would say the real world has intruded in a variety of ways. The next slide. It's interesting that you get all kinds of people making a case why they should be first or should be in phase 1A. In this case, department store Santa Clauses made the case that we needed Christmas at the end of 2020, a bad year, and that they should be in the very first tier. But the department store Santas were hardly the only people making their case about why they should be near the head of the line. The next slide. Pretty much everybody agreed, all the various committees and whatever, that healthcare workers, high-risk healthcare workers, including the people who clean the rooms and the people who wheel patients around, so not just doctors and nurses, should be at the very top of the list. So in general, pretty much every state prioritized healthcare workers. I should have mentioned that whatever the federal government says, I think many of you know that we don't actually have a single nation when it comes to health or public health. And fundamentally, each of the 50 states and each of the territories and the Indian tribes fundamentally could pretty much do what they wanted in terms of prioritizing groups, as I'll show you. The next slide. Then after healthcare workers, there's lots and lots of discussion and disagreement. So for example, is it more important to vaccinate the frail elderly in nursing homes first, or the people who deliver and grow our food, or our school teachers? So who's an essential worker? Where do they stack up in comparison to the elderly? What about people in prisons or other types of facilities? And very different conclusions have been reached about these priorities by different groups. So it's really been kind of a mess, to be perfectly honest. The next slide. State of California, like pretty much every state, developed its own vaccination plan. You can go online and read the current version of the plan. So this just shows, for example, as of February 13th, that California said healthcare workers and long-term care facility residents should come first. That's about 3 million people in California in phase 1A. And then food and agriculture, education, childcare, emergency services, that's another 6 million people. People over 65, another 6 million people. So if you're interested, you can go online and read these allocation schemes. Again, they vary completely from one state to another. And unfortunately, within a state, they seem to vary over time as states adjust to political pressures and other considerations. The next slide. So here you can see that there was a backlash in California about people with disabilities not being prioritized. So California changed its eligibility criteria so that people with disabilities would be higher on the list. I think anyone on the call can understand how complicated and difficult these discussions are, and I'm sure some of you will have views on the subject. The next slide. In any event, of course, there are other problems beyond priority setting. The fundamental one are the logistics of, in fact, giving vaccines to large numbers of people, and how you sign up to get a vaccine. And again, you can go online if you're a California resident and see what the state of California advises with regard to in regard to this. The next slide. This the New York Times as a week ago in terms of how we're doing. It's estimated that about 15% of the U.S. population has received at least one dose of these the two-dose regimen vaccines, and that about 7 or 8% have received 2 doses. Some states are doing better than others in terms of achieving higher levels of coverage. But there's just enormous variation from one state to another. I should say that because your tax dollars paid for all these vaccines, they basically have all been bought by the federal government. The federal government ships them to states, and they do it based on the allocation is based on percent of the U.S. population. So if California is 12-14% of the U.S. population, they get 12 to 14% of the doses of vaccine, and it's strictly based on population size. The next slide. We're currently vaccinating about 1.5 to 1.7 million people a day. Of course, as the next slide shows, this has produced some interesting challenges. When you throw open the gates, if you will, to say everybody in this group should get vaccinated, in many states, the result has been websites that crash, long lines of people in their picnic chairs with meals with them to wait in line all day, long lines of cars waiting to go through drive-in sites. And so whenever states have expanded eligibility, we end up with people having a difficult time accessing the vaccine, even if they in theory are at that point qualified to get it. The next slide. So here you can see in Los Angeles, they had to shut down a number of large vaccination sites because they didn't have enough vaccine. And so the balance between vaccination sites and numbers of doses and who should show up and who can make an appointment is frankly been kind of a mess pretty much throughout the country. The next slide. There's been a question about, fundamentally whether any doses should be sitting in freezers or whether they all should be in someone's arm. So attempts to get back unused doses from various places. A lot of controversy about whether we should be keeping your second dose for you in a freezer, as opposed to just giving everybody as many a dose and not worrying about the second dose. I'll be happy to talk about that. It's very controversial. The next slide. We had a bit of a problem with the weather a week ago in much of the country, and that made it impossible to ship vaccines for a day or two. The next slide. This is an example of a 90-year-old woman walking 6 miles in the winter to get her dose of vaccine. I don't have her picture here, but obviously a formidable individual who was going to get her vaccine one way or another. The next slide. We have people impersonating old people to get themselves vaccinated. This occurred in Florida. The next slide. We have senior living communities offering the vaccine as an amenity. If you move into this senior living community, they say they can get you, vaccinated sooner. Next slide. Massachusetts has a program in which, because a lot of the older people have trouble getting to vaccination sites, that basically if you give somebody a ride to a vaccination site, you too can be vaccinated, which has led a number of younger people to go out hunting for older people they can take to the vaccination site so they can get themselves vaccinated. I mean, you can tell that this is really kind of a challenging set of approaches across the country. The next slide. Again, the CDC has now tried to help in terms of people finding vaccines, but I suspect there are people on the call who themselves have been frustrated, have wanted to get vaccinated and been unable to do so. So this remains a substantial problem in California and elsewhere. The next slide. I didn't watch this, but apparently Dr. Fauci was on Saturday Night Live over the weekend hosting a game show, So You Think You Can Get the Vaccine. So you can tell, public health has reached new levels of recognition if Dr. Fauci is hosting a So You Think You Can Get a Vaccine show on Saturday Night Live. The next slide. None of you will be surprised. We're a school of public health and we understand disparities. None of you will be surprised that in our country, vaccination coverage and rates of vaccination are lagging substantially in Black and Hispanic communities. There are a variety of reasons for this. A lot of people quite, working hard to try and change it, but some of this has to do with access to the internet and computers and being able to go online and get yourself an appointment. Our National Academy report dealt in great detail with trying to prevent there being racial and ethnic disparities in vaccination, and the country has certainly not been able to accomplish that so far. The next slide. Pretty much across the country, Blacks, Hispanics, and immigrants have the lowest vaccination rates. And even when vaccination sites are set up in low-income communities, a lot of people from wealthier communities come and get in line or get appointments and take up a lot of the vaccination. The next slide. So our new president, as you all know, has a goal of giving 100 million vaccinations in 100 days. That will probably be surpassed, which is certainly good news. The next slide. Here's one guesstimate as to when everybody will be vaccinated. I think my own estimation is that basically by the middle of the summer of this year, anyone who wants a vaccine will be able to get a vaccine. That's not true now, of course, but by the middle of the summer, it should be. I know it's frustrating having to wait, but these are the projections. The next slide. But all of the vaccination currently is for people ages either 18 and above or 16 and above, depending on the vaccine. But there currently is no vaccination of anyone under the age of 16. And so the next slide, and we can skip that. We have other vaccines coming, including we hope from AstraZeneca and Novavax. FDA has said that in terms of trying to vaccinate against the variants which keep appearing, that should be able to be a fairly fast process. It won't require clinical trials. It'll be based on immunogenicity and in vitro studies. The next slide. And there are lots of complexities now. So, now it looks like the Pfizer vaccine doesn't need ultra cold storage. Regular freezer temperatures may do. There's reasonable evidence that the Pfizer and Moderna vaccines provide a reasonable level of protection after one dose. And that's why there's some controversy about whether we should save second doses for people or not. There's some evidence that people who've had COVID-19 really may only want one dose of the vaccine instead of two. This is another complicated area, which I'm happy to talk about. The next slide. And of course, now that we're giving the vaccine to millions of people, particularly frail elderly people, but all kinds of other people, bad things happen to some people shortly after they're vaccinated. I just got an email today, in fact, from somebody asking about whether there are too many deaths in frail elderly nursing home patients within the days following vaccination. So, when you do anything to very large numbers of people, however benign, some of them will get sick or die within days of whatever you did to them. And so this is a very important issue, monitoring the safety of these vaccines and trying to establish that, in fact, if there are any suggestions of adverse events or increased mortality, that those are thoroughly investigated. And I would say so far, the evidence is that the current vaccines are very, very safe, and that there's no evidence, for example, of an increased risk of death. So this is just a headline concerning the fact that CDC already was putting out data on about the first 1.5 million vaccine recipients. So safety is being monitored very carefully, but there's lots more work to be done about that. The next slide. And of course, so this won't surprise anyone, but there's enormous misinformation about the vaccine that's on the web and everywhere else. That's got a microchip in it, for example, and the government will be monitoring your movements if you get vaccinated, to a host of other things. Yesterday, the Catholic Church in New Orleans raised objections to the mRNA vaccines around issues of fetal cells, or some of the cells used being the long descendants of cells that might have come from a fetus in the 50 years ago. So that's just lots of issues that people are raising about these vaccines. The next slide. There's people on the web saying that the vaccines cause infertility. There's absolutely no evidence to support a statement like that. The next slide. We have the whole issue of misinformation on sites like Facebook, and what, if anything, can or should be done about all of this misinformation, and whether Facebook and others have responsibilities to in any way edit or remove material which is demonstrably untrue. I'm sure we could have a good discussion about that. The next slide. The concerns about the safety of the vaccine are pretty much across society, but there is even greater distrust, some people assert, in Black and communities in particular, because of Tuskegee syphilis studies of 50 years ago, and other really lamentable things that have been done. So this may be one additional impediment to vaccinating as many people as we'd like within the African American community. The next slide. So if I could, as I've said, so far the evidence is that 1/3 of people in the military are refusing vaccination, and apparently because these vaccines are approved under emergency use authorization rather than full licensure, the military cannot compel people in the military to be vaccinated the way they did with anthrax vaccine 20 years ago. If these vaccines get full licensure, the Department of Defense, I believe, could compel service members to be vaccinated, but at the moment, many of them are refusing. The next slide. And of course, this raises the very interesting question of whether your employer can mandate vaccination or not. My lawyer friends tell me that your employer can, in fact, mandate vaccination, and that would stand up to legal challenge, but there may be people on the call who know more about that than I do. The next slide, and I'm almost done here. As these vaccines roll out, the key issues are, assessing coverage, what proportion of people are getting the vaccines, how does that differ in different communities and populations, how effective are the vaccines in preventing various outcomes, what impact are the vaccines having on the pandemic, and of course, the many, many issues relating to safety. The next slide. Just a brief word about the fact that we have a great deal of inequality globally with regard to access to vaccines. So fundamentally, all the vaccines have been bought by rich countries. Some countries like Canada have enough vaccine to vaccinate their entire populations several times over, while poor countries basically have been shut out of this process. This happened with the flu pandemic in 2009, and certainly was no surprise to anyone. The next slide. The attempt to deal with this is called COVAX, and COVAX is the vaccine part of a COVID tools accelerator. This has been put together by Bill Gates and other rich people and countries. Their initial hope had been to raise $18 billion. I believe that number has now gone up in terms of what they're trying to raise, but they're well short of any goal. But the plan, the hope is to basically buy enough vaccine to give to the world's poorest countries so that they too have access to COVID vaccine. The next slide. The Trump administration refused to participate in COVAX, but the Biden administration has recently committed $4 billion to this effort, and so that will certainly give it a shot in the arm, so to speak. The next slide. Almost done here. And so the first COVAX delivery of vaccines was to Ghana last week. I would point out that COVAX is primarily targeting the poorest countries in the world, just like something called the Gavi vaccine initiative. and middle income countries or countries that aren't quite poor enough for COVAX may not really get much help from this program, and it may leave countries that are not quite poor enough in somewhat of a bind when it comes to these vaccines. The next slide. Of course, it also raises the issue, in terms of who will get access to the vaccines in middle-income countries. And of course, it's likely to be the rich and powerful. The next slide. So in summary, vaccines are here. We have 3 for use already in the United States. We expect a couple more to come online within the next few months. But there clearly are many, many challenges with regard to distribution, reaching priority groups, building confidence in the vaccine, monitoring safety and effectiveness. And then finally, my next slide is, even if you're vaccinated, you may still need to wear a mask. And, we can talk about that. But the likelihood is that we're all going to be asked to continue to do social distancing and mask wearing for some period of time, despite growing numbers of people vaccinated. So let's have a discussion.
Thank you so much, Art. That was really fantastic and super informative. People want to add questions in the chat. I see we have one I can start with, but if people want to do that, or you can raise your hand and I'll call on you. How do you address the concern about the use of fetal cells in the vaccines? That's one question. And are there differences in how fetal cells were used in the J&J vaccine versus the others? Do you know?
So I admit that I don't know. We had in our working group last night, we talked about the fact, because, as I said, the New Orleans Archdiocese issued a report yesterday calling into question whether these vaccines at some point in the past had benefited from cells derived from a human fetus, and if so, whether Catholics could receive these vaccines, should receive these vaccines. I don't know the answer to that question in terms of what was used and whether you can legitimately trace it historically to some fetal cell line or cells developed from a fetus in the past. So I can't answer that question. And maybe someone else on the call knows the answer to that question. The issue of religious and theological objections to vaccines is a much wider question. I don't know what to tell people. Presumably, if there turn out to be other vaccines where there's no trace of fetal cells, human fetal cells in the history of anything product in the vaccine, then maybe those would be more acceptable to people.
Mm-hmm. There's several questions about what is the data shown regarding vaccinated people transmitting the virus, or the likelihood of whether.
Right.
Yeah, and is it too soon to say, or how do we know? How are we going to know?
So the first question is whether the vaccines prevent infection, not just disease. And there is evidence, particularly good evidence now from the Johnson & Johnson vaccine, that the vaccine does prevent infection, even asymptomatic infection, to a large extent. And if it prevents infection, it should prevent transmission. But the main approach to looking at this so far has basically been more of a laboratory approach. The epidemiologic approach to answering that question is a really difficult type of study to do, in which, and this has been done for some other diseases, but if you're an epidemiologist, the way you study this is you look at somebody who has COVID-19, and if they live in a household with other people, you look to see if they transmit to other people in the household or not, and whether that varies by whether the case was vaccinated or not. And whether vaccinated people are less likely to transmit to others in the household. They're basically a form of a cohort study, with every household being a mini cohort. Those studies may be impossible to do for this infection. But the evidence from the trials so far, and I'm pretty optimistic that the vaccines we have so far do prevent infection and are likely to prevent transmission. But how completely, I don't know.
Okay, thank you. Lisa Barcelos is asking, can you say anything about how you might imagine instruction in person happening in the fall? And has there been anything announced by our chancellor or other UC campuses as well?
Well, my understanding is the chancellor so far is saying that we're going to be on campus in the fall, doing in-person instruction. But of course, that's subject to revision and change over the coming months. I think, there's a big piece in the New York Times today about the question of vaccine passports. I alluded to the question of, can we mandate vaccination or not? Could the University of California mandate that all faculty, students, and staff be vaccinated to be on campus? If there's a lawyer on the call, they successfully have mandated other types of vaccination for students, at least measles for immunity, for example, and last year influenza vaccination, which was legally challenged but survived the challenge. So, would we potentially mandate? There's this whole question of immunity passports. Do you need to prove that you're immune in order to come to class, in order to use the gym, in order to get on an airplane? These are immensely complicated and difficult discussions. But Lisa, I'm planning to be on campus teaching in the fall.
Great, thank you. Any ideas on when children under the age of 12 will be able to be vaccinated and what method of vaccination might become available or developed? And what about likelihood of vaccinating breastfeeding moms? Do they pass it on, the antibodies, to nursing babies?
So trials in kids down to the age of 12 are enrolling now. I seem to have left out that slide. I thought I had it in here. So there are trials already in kids down to the age of 12. There are plans for trials in younger children, but I don't think any are enrolling yet. So I think in terms of next school year, nobody under the age of 16 is going to be vaccinated. And I think that vaccination of children is at least, not going to happen certainly by the summer or next fall. Ultimately, it may well happen once those trials are completed. The trials will probably look mostly at immunogenicity and safety and not have clinical protection data. With regard to breastfeeding women, my daughter, I have two daughters who are both breastfeeding at the moment. One of them is a frontline physician, and she certainly got vaccinated. And I completely agreed with her decision to do that. There's no evidence that the mRNA vaccines are in any way harmful in either pregnant women or breastfeeding women. The recommendations are that, that the benefits for many women, the benefits far outweigh any possible risks because there aren't any known risks. People argue that, well, it's an mRNA and what the hell do we know about mRNAs? Your question about passing the antibodies down to the baby, that certainly is true for many other vaccines, where we intentionally vaccinate pregnant women to protect newborns against whooping cough, against influenza, against tetanus in some countries. So, we just don't know yet. But I would certainly not. I believe that the vaccines can be safely given to pregnant women and to breastfeeding women.
Thanks. And how will mutations like the South African variant be addressed, do you think?
So the data from the studies of the Johnson & Johnson vaccine just approved actually is the first study, the first vaccine in which we actually have data about how well the vaccine worked against variants, and it worked quite well. There are concerns that some of the other vaccines may not protect as well against some of the variants. And of course, there will be a constant stream of new variants because the virus is constantly under pressure and evolving, and new variants will inevitably occur. And so we don't know that these vaccines will protect against all variants. And that's why companies are already experimenting with vaccines that, that potentially could be boosters or annual shots or provide you protection against a new variant. And that's why the FDA has already said that they will not require a full randomized trial in order to approve vaccines and similar vaccines that address the variant. So the answer is we just don't know, frankly.
Mhm. Okay, great. Well, we're on 12:30, so I want to thank you very, very much for the very informative and great presentation today. We really appreciate your time, and thanks to everyone for joining today. And we did record the session, so we will be posting it as well. So thanks very much, Art. Everybody have a good day and be well. Getting lots of thank yous in the chat. So thanks very much.